Happy to have with us at the 2011 ONS conference in Boston, Massachusetts, is Dr. Jane Armour from the University of Missouri School of Nursing. Thanks for stopping by.
My pleasure. My pleasure to be here today.
Okay, so you have an abstract about the assessment of genetic predisposition to secondary lymphedema. What can you tell us about that?
This exploratory work looking at the genetic predisposition to lymphedema, to secondary lymphedema, is based on the hypothesis that there may be some genetic reasons that some women after breast cancer develop lymphedema and others do not. We know there are risk factors associated with the development of lymphedema, but we still can't explain why one woman with the same treatment, with the same body size, the same stage of cancer will develop lymphedema and another woman doesn't develop lymphedema. And we think there may be some innate differences in their lymphatic system that may help us to identify who's at higher risk with certain cancer treatments versus who's at lower risk.
Doctor, there's really two outcomes here. Can you talk about them?
Yes, the first would be that if we can identify those with higher risk, we can really target the educational information on risk reduction for those women so they know how to monitor and what they can do in their lifestyle to reduce the risk of developing lymphedema. The women at lower risk may not need to be so vigilant in their monitoring. They still would have lifetime risk, but lesser risk than those that have some genetic predisposition. The other impact that could come from this exploratory work is that we may be able to actually make different cancer treatment decisions. For example, mastectomy versus lumpectomy and radiation. In a person who's at higher risk of lymphedema, the physician and the person at risk might discuss those treatment decisions and make a decision individualized for that woman based on her profile of risk for developing lymphedema.
You're taking a pioneering look at secondary lymphedema. This is a condition that affects a great many breast cancer survivors. Would you discuss the impact here?
I'm glad to do that. We have another study that we're nearing completion on where we have followed 300 women from the time of their diagnosis of breast cancer before they had surgery or radiation over a period of 7 years. So we can document that depending on the criteria that's used and the method of assessment, that approximately 40% of women will develop swelling. It may be transient, it may be chronic, it may be mild or severe, it may be distressing or less distressing, depending on the characteristics they experience. But we know that about 40% of women will experience lymphedema during their lifetime over the next 60, 72 months after the breast cancer, or even as late as 20 years later. It does impact one's function, one's activities of daily living, can affect one's recreational activities or work activities, how we care for family, and it also affects one's self-image, how one cares for oneself and sees oneself. So it does have a rather profound impact on the individual and on the family, and somewhat a burden for society in terms of the economic cost of lymphedema. There's a recent study that shows that the woman who's treated for breast cancer who develops lymphedema will pay out more than $20,000 difference over 2 years in care for herself, for not only the breast cancer, but the other treatment sequelae that occur. And so we know there's an economic impact of lymphedema as well on the individual and on society.
Now, 40% or higher is a pretty big number. Still, you feel this is a condition that is overlooked. Why?
It is. If we're not observing for the condition, it's very easy that it be ignored. If we're not measuring limbs or asking women if they experience symptoms, the women may not volunteer that they're having this difficulty. They may expect that it's a natural outcome of having had breast cancer and breast cancer treatment. We found that when we actually measured women returning for cancer treatment over a period of time, 40% of those women were measurable to have lymphedema, but only half of their medical records had a diagnosis of lymphedema. That was the very first study that we did back in 1999. And when I talk to physicians today, they often say they don't know that their patients experience lymphedema, or they might see one patient a year with lymphedema. But when you ask if they're measuring women or asking them about symptoms, they will acknowledge that they're not often asking those questions or observing the arm unless the woman points to some difficulty.
Doctor, what should be done now with this information you've acquired?
We need to inform women, certainly, that it's a risk that they may develop lymphedema after cancer treatment, and we need to encourage them to monitor their limb, to care for themselves. There are certain self-care practices that impact the development of lymphedema. We believe they should protect that arm from constriction, from carrying heavy bags on that limb or on that shoulder, shouldn't have blood pressure checks on that arm or lab work drawn or chemotherapy in that limb. That's sometimes a controversial area because as we do sentinel lymph node biopsy and lumpectomies, sometimes it's felt those risk reduction precautions aren't needed. But we still see women with low risk of developing lymphedema develop lymphedema some months later. So we still do need to protect them with those areas of avoiding constriction or repetitive action that causes swelling, maintaining an optimal body weight, those things that we can do to keep ourselves healthy and prevent the occurrence of lymphedema if at all possible. If lymphedema does occur, there's very good management for lymphedema. It doesn't go away, but it can be well managed for the lifetime. There is care that can be delivered, and that's another area that is overlooked. Sometimes people think there's nothing that can be done. It can be properly managed.
Dr. Armour, thanks for stopping by and spending some time with us and sharing your work.
It's my pleasure. Thank you for the opportunity.
Talking secondary lymphedema with Dr. Jane Armour here at the 2011 ONS conference in Boston, Massachusetts.